Hello, thank you for joining me in navigating complex treatment landscapes in oncology, particularly focusing on clinical pathways in prostate cancer. My name is Dr. Elizabeth Heath, and I have the pleasure of being the Associate Center Director of Translational Sciences at the Karmanos Cancer Institute in Detroit, Michigan. These are my disclosures. I hope to share with you 3 learning objectives today. The first is to summarize the impact of integrating emerging therapies into clinical guidelines and pathways in prostate cancer, to outline the latest clinical safety and efficacy data surrounding current and future treatment options in metastatic and non-metastatic CSPC and CRPC, and also to integrate recent therapeutic advances and unique cost considerations into prostate cancer clinical pathways discussions. Sometimes the best way to approach prostate cancer, because it is a complex disease to treat, is to use the clinical states model. The clinical states model really helps us understand where to categorize your particular patient is in his disease journey. You can see that it starts at clinically localized disease all the way to multiple lines of treatment in the metastatic castrate-resistant space. The items in the box are just updates that's occurred over the last several years that sort of better define this journey. And I think that it's also become evident for those of us in practice that management of prostate cancer is really quite complicated these days, and we now have different team members joining us for multidisciplinary team discussions. It's not often, maybe 10 years ago, that we would have thought about having clinical genetics, palliative care, and other subspecialties join us, but it's really important to recognize, as we're talking about the care of patients today with prostate cancer, that it is a multifaceted disease, and we need all the help that we can get to be able to treat patients. So one of the ways to, I think, really understand how to apply the clinical states and to kind of learn what's really new in this area is to follow along with our hypothetical patient. This lovely hypothetical patient that we'll call Mr. Jones for today is a 62-year-old African-American male who started having rising PSA to a level of 8. He has a medical history that's common to many of our patients, including hypertension, hypercholesterolemia, and a pretty significant family history. You can see a brother with prostate cancer at the age of 60, a sister with breast cancer at the age of 45, and an uncle with prostate cancer at the age of 65. He's relatively asymptomatic, perhaps a little bit of mild nocturia. Now on the digital rectal exam, he's a T1C, which means it was slightly enlarged, but no nodules felt. And then he underwent a biopsy. And the biopsy results show a Gleason 9 of 5+4 with 8 out of 12 cores positive for Gleason 5. So for the rest of the discussion today, we're going to follow along with Mr. Jones and what's really happened to him and what are the treatment options available. For the guidelines, there are many in this current situation. NCCN, ASCO, ASTRO, AUA, as well as the Prostate Cancer Working Group 3 guidelines are all there to really help us. And it's obviously in this particular patient that he hopefully has clinical localized disease. But to really know that, I think it's important to understand what is his risk stratification and what kind of staging workup does he need. If you really look closely at the data available, he really falls into the very high risk category. He has multiple cores, and all you need is 4 of a grade 4 or 5, and also having a Gleason 5 puts him in this risk. We have always tried to parse out the risk based on low, intermediate, and high, but more recently, having a very low and a very high helps manage the patient a little bit better. So he will need a bone scan as well as the other recommendation on this slide, but also recognize that his treatment options are pretty diverse. He might be able to be a candidate for external beam radiation therapy with hormone therapy, but I'd like to point out that the addition of docetaxel, or at least a discussion of docetaxel, which is a category 1 indication, is somewhat and often overlooked for our very high-risk patients, and we'll get to that in just a second. The other opportunities also include external beam radiation therapy plus brachytherapy and androgen deprivation, or radical prostatectomy with a lymph node dissection. So these are pretty diverse and I think warrants thoughtful discussion for a patient like Mr. Jones, who's 62 and otherwise quite healthy. One of the questions that come up sometimes in the discussion is, how do we or practitioners or patients understand what's really happening perhaps in our local area with regards to how patients are doing or what are the statistics? In the state of Michigan, we're very fortunate to have a collaboration known as Michigan Urological Surgery Improvement Collaborative, or otherwise known as MUSIC, very, very prominent in our state. And why this is important is because we have physicians who truly believe that quality of improvement in the area of radical prostatectomy and just the overall care of our prostate patients is very important. So there are several practices in the state of Michigan who have joined into this MUSIC collaboration. And these are some of the requirements that you can see here, that they at least see 15 adult men with prostate cancer annually and are affiliated with Blue Cross Blue Shield. They have a variety of different projects, including the MUSIC PRO project, where patients themselves answer questionnaires. And I think that's really important to understand how we can improve outcomes. What happens to a particular patient will be captured, and his experience will be important, and it will be shared. This type of initiative is quite important, I think, in terms of how we move forward as a collective body. This type of collaboration between Blue Cross Blue Shield and the physicians who are very, very invested in making sure our patients get the best care is something that should be modeled as we move forward in other disease considerations. So back to this patient, when you're having a discussion, which I actually recently did have a discussion about a month ago with a patient that was categorized as a very high-risk patient, and we talked about the role of docetaxel. And the reason why this is important is because there is actual data to support its use. Again, guidelines don't put category 1s without data. And in this case, the RTOG 0521 has shown that overall survival did improve from 89% to 93% in patients who received 6 doses of docetaxel. Now, this study was reported with their data at a 6-year disease-free survival. There was a recent update, which was done at 10.4 years, where the overall survival sort of didn't become statistically significant. So it was really a 69% versus 64%. There was a decrease in the 10.4-year rate of distant metastases. So I was able to share both sets of data with my patient. Eventually, he opted not to, due to his concerns about diabetes and the fact he already had emerging neuropathy. Now, in our hypothetical patient, where he didn't have those comorbidities, I do believe that a discussion is warranted, especially in these very high-risk patients. So this is one of the take-home messages for patients who are newly diagnosed. Please understand where they are in their risk stratification and staging. Now, in addition to that, if I expand this table, there's also germline testing now that's part of the workup. And this sometimes is often missed, but really important because, as we know, prostate cancer is a genetic disease. We have understood in the past for other cancers like breast cancer and ovarian cancer the need for genetic counseling, but metastatic or high-risk prostate cancer falls now into this bucket. So again, that's just not very high risk, that's also high risk for a recommendation. So that means when you're seeing this locally advanced patient, you're thinking about sending this patient to see a genetic counselor. Most of us in practice work with a terrific genetic counselor or genetic counseling team, but if you don't, there are options for you to be able to navigate this landscape. And I highly encourage you to think about this, as this is now very important, especially as we think about disease in the later stages. So now we're following again Mr. Jones, and he's done well after his treatment of radiation and ADT. And now, all of a sudden, 3.5 years later, his PSA started to rise. So many of us would go to the nomograms. In this case, Mr. Jones had the MSKCC nomogram equation, and the doubling time was at 10 months. He's perfectly fine. There was no symptoms whatsoever, but his PSA started to rise, now at a level of 2.8. So in this situation, he is not castrate, he says full testosterone, with a rising PSA. And many of us encounter these patients. They feel fine, but they're now concerned that the PSA is starting to rise. So there are some next steps. I think many of us now have discussions with our patients. Do we do a bone scan? Should we do some sort of PET scans? How about an MRI? How aggressive do we go? I think that many of us understand that there's no one perfect answer, but there are some guidelines. But I just want to mention that part of this really depends on you and your practice. So for example, we order scans, often that we're denied. Sometimes we stop, sometimes we appeal. All of this, though, is a somewhat cumbersome process. So working out perhaps an SOP or a standard operating procedure for your practice or for your group might be helpful so that many of us are not frustrated with getting constant denials. However, in some instances, it might be warranted that these scans are denied because they are costly and we need to know really what we're trying to do with them. So let's take F18, fluciclovine PET CT scans. In this case, and in this example, what we find are very small lymph nodes that maybe would not have been called on a CAT scan, but all of a sudden on a PET scan lights up. And perhaps that affords us some opportunity for local therapy, be it radiation, cryotherapy, or even surgical resection. But I think these are some of the outcomes that we hope for, at least in terms of sharing with our patients. Now, the guidelines are as such. NCCN does support the use of F18 fluciclovine PET CT scans, especially in the workup of a potential recurrence of the prostate cancer. So does the American College of Radiology. Currently, this is covered by Medicare in men with suspected prostate cancer recurrence based on the PSA following prior treatment. So I think a well-balanced discussion with your patient in terms of what he or you or his family member, or whoever has a decision-making capacity, wants to do about the rise. The patient certainly does not have any issues clinically with the rise, other than, of course, it's quite worrisome and disturbing, and everyone wants to know where the cancer is. In fields of research, I think the world of PSMA PET CT scan has definitely exploded. I am showing the schema just to show you that there are many, many different friends that PSMA can tag with. And that sometimes complicates the issue because some are more research, some are a little closer, but none of these are at this moment approved by insurance. So one way to gain access to these PSMA scans would be to go on a clinical trial. So if you go on a clinicaltrials.gov search, as I did recently, there are actually 60 trials that are actively accruing for diagnostic PSMA. Your out-of-pocket costs in the United States can vary, but this is where knowing the landscape that's in your own backyard is very important. And I think we all would like to do a PSMA test of this capacity because, as you can see in item B, it tends to be much more sensitive than perhaps a bone scan, as you can see in figure A. Another type of PSMA trial that is already ongoing is listed here. This was just recently reported where 70% had the PSA level up to 2 in our hypothetical patient. It was higher than 2, and you could see what the positive predictive value is. So this is an important discussion to have with your patients. More often, they will be the folks who actually bring this to your attention as everyone is becoming much more aware about imaging capacity. So moving ahead, our hypothetical patient did do some imaging. There was no evidence of metastases. There was a consideration of a clinical trial for his rising PSA. And at the end of this whole thing, he just decided, I'm going to move on and get my ADT started. I don't want to sit here and do more testing. So in this scenario, it's really important to also ask, well, gosh, is androgen deprivation really just injections? So I want to call to your attention a recent study just out this year called the HERO trial, where injections were compared to a new drug that is oral. So relugolix at 120 milligrams daily after a loading dose was tested against leuprolide, and you could see that some of these results really show some equivalency. So to be on the lookout, this may move forward in the drug approval schema, but to be aware that perhaps our options may change in the recent, moving up here in our recent future, to figure out whether injections or pills might also be an option for our patients. So coming back again to Mr. Jones, he was treated with androgen deprivation for 18 months. He did well, really had some hot flashes, but was able to tolerate it. And he achieved a PSA that was undetectable. And then at 18 months, the PSA starts to go up again. Now the doubling time is even faster at 8 months. Again, standard imaging studies were obtained and no evidence of metastatic disease. So now he's in this non-metastatic, but he is now castrate because his testosterone has been suppressed with ADT. So this is now a new space where it's really important to recognize that although the patients have been on androgen deprivation and the PSA is rising, we can't figure out where the cancer is. I do want to call to your attention, though, that when we give folks or start folks on androgen deprivation therapy, that we always have a concern about metabolic syndrome. So with this discussion of getting that PSA down, the other part to that well-balanced discussion is some of the side effects that may be short-term and long-term. In our own study here in Detroit, we had looked at clusters of conditions that define metabolic syndrome, like hypertension, high cholesterol, central adiposity, and high blood glucose level. And as you can see here, that in this community-based case control study that was also done as part of the Flint Men's Health Study, that it was really important to show that the metabolic syndrome rate is much higher in the African American men. And we put this because we understand that ADT, short-term or long-term, can have some consequence, and it's something to think about as it may affect your treatment choices. Now, in our hypothetical patient, Mr. Jones, he would have also been encouraged to do nutrition as well as exercise. As we know, our own internal data shows from our survivors of prostate cancer that less than 25% of them do any physical activity of 150 minutes per week. So many in our catchment area have access to a CrossFit program, but I encourage all of you in your own practice to really figure out how these kinds of conditions can be offset. So part of that discussion is, of course, because we're very fixated on the androgen pathway, and everything from this point in the lecture on always comes back to this issue of why is the androgen receptor still involved? And yet it is. So back to our patient where the PSA is rising and the ADT has provided a testosterone level that's very low. We now have 3 different options, and this is relatively new information. So important for you to know that this clinical state of M0 has 3 medicines that are approved: apalutamide, enzalutamide, and darolutamide. And it also highlights a very new FDA approvable endpoint known as metastasis-free survival. So the FDA actually published a guidance, a PDF document that you can access here, where in November 2018, it was this recognition that if we were waiting for overall survival, we may be waiting a very long time for these trials to complete. So in the interest of time, I will just scroll to show that in the Spartan study, apalutamide was checked, but that there are certain side effects that are a bit different in each type of androgen receptor blocker. So in this instance, there was more hypertension with apalutamide, as well as a rash and some fractures and some dizziness. But if we look at it for men who were in the greater than 75 years of age, the falls and fracture rate is definitely much higher. In the PROSPER study where enzalutamide was evaluated, these side effects were a slightly different profile with more in the cardiovascular realm. And in this instance as well, there was a 15% mortality rate, which really was sort of death without documented progression. So again, something to consider for patients who have cardiovascular disease in terms of treatment selection. And then the third study is the Aramis study, which then evaluated darolutamide, where both sets of side effects were actually considerably less, potentially due to less CNS penetration of this particular medication compared to its others. So that was a quick run through the M0 state, but it's really important to know that this clinical state actually has some medications involved. Now, this clinical state may theoretically go away in the next several years with better testing, but at least at this point, these options for treatments are available. But let's talk about cost, as these all seem to be somewhat the same in terms of the oral administration. I did ask our own Carmano Special Pharmacy if patients were to pay out of pocket what the cost differential would be, and I list those there for you. Abiraterone, which was not successfully tested in this realm, which is considerably cheaper, is also a possibility, but really without any data support. So it's important to understand not just the side effect availability, but also where the cost considerations may be important. So back again to our Mr. Jones. He has been on, these ADT, but let's pretend he actually presented for the very first time, that I didn't have the option to see Mr. Jones from when he was diagnosed with his very high-risk disease. Many of us in medical oncology and urology and other subspecialties sometimes still in 2020 get called, particularly to the emergency room, for new onset or new diagnosis of metastatic cancer. So in this instance, it's, I think, really important that you are aware that in the M1 now, castrate-sensitive space, we definitely have treatment options. So had I seen Mr. Jones right off the bat without knowing him, he would have gotten ADT for his bone and lung metastases, but he would have also have had certain options. One of them, again, is chemotherapy. The trial design of the charted study is on the left, and the overall survival curve is on the right. And as you can see here, there's definitely a benefit with a lower hazard ratio for those who receive docetaxel. And it does matter in terms of the extent of disease. Those with high volume metastatic disease has a better improvement, and high volume defined as visceral metastases or 4 or more bone lesions. I think it's also important to know that that study that was now, many years ago, had an update a few years back in 2018, and that data is still holding. So chemotherapy is an option in addition to ADT for the M1 CSPC patient is definitely there. There are other trials you should be familiar with. One is the GETUG trial, the other Stampede. The GETUG was not positive for improvement in overall survival. As you can see, the curves are now on top of one another, but Stampede was. So the important part here is that standard of care has evolved now to have a discussion about docetaxel, especially in the higher risk or high volume patients. But again, back to our androgen receptor pathway involvement, abiraterone, which is an oral pill, is also available. And both studies that it was studied in, Latitude and Stampede, does support its use. Now, if you say, do we know if docetaxel is actually better than abiraterone or vice versa? The answer is we don't know. But goodness, we do know. And especially in the high volume, high risk, it seems to be somewhat equivalent. So I think in the sense of having a well-balanced discussion, it's really important to understand that both options are available, as are other options. So thank goodness in oncology, we tend to run more than 1 or 2 trials at a time. And our Titan study actually also supports the use of apalutamide in this instance. And there's also important to recognize that 37% of the patients on Titan, where they were given apalutamide versus placebo in addition to their ADT, were of low volume disease. So that answers the what do we do with the low volume folks? The other trial is with enzalutamide, and this is the ENZAMET trial, where nearly half of these patients had low volume disease. And the ARCHES trial is also enzalutamide, where it's 38% low volume disease. So if we were to summarize the M1 CSPC state, you can see that considering different toxicities in the treatment decision-making is really important. Whether you're worried about neuropathy or you're worried about prednisone use or any other treatment toxicity, it's important that all of that gets discussed and included into the treatment decision-making. And again, understanding that ADT is still a very powerful, important step, and that perhaps if your patient has too many comorbidities, that ADT alone may be sufficient. And of course, we always dissuade against combination use. So many folks will say, well, what if we just pile on all the medicines? I think none of the studies support that, but the sequential use of docetaxel plus an AR is currently being studied. So moving on to our patient again, he had started on apalutamide. He tried to get the darolutamide, and again, I say that only in my own practice. Sometimes I struggle with getting the pills that I want due to insurance constraints, but nonetheless, they all have overall survival benefit, and it's really important to know to not give up and to continue to work with your team and your nearby resources to really know how is the best, or what is the best possible way to create a treatment option that's reasonable for your patient. So in this hypothetical, Mr. Jones, he at some point again continues to have worsening disease in the bone and the lungs, and now he is truly castrate resistant. So one of the questions that usually comes up is, does it really matter where the location of your cancer is in terms of our discussion? And the answer is yes. In this terrific paper by Dr. Halaby, published several years ago, it shows that if you have lymph node only disease as a stage 4 or a metastatic castrate-resistant prostate cancer patient, you'll still live a lot longer in terms of median overall survival compared to those with liver. I think having this important data at the tip of your hands in terms of clinical discussion in the clinic is important for two reasons. One, also for sort of prognostic and goal setting, but number two, to be able to take things like cost and quality of life and visits into your doctor's office as part of this discussion, knowing what the natural history of this cancer is going to be. In terms of treatment options for M1-CRPC, there are many. And I think that in this instance, we have been very fortunate in the world of prostate cancer that many of the trials run in the last 14, 15 years have been successful. And as an investigator during this time, I'm excited to at least have a menu of items to have for my patients. However, equally important in understanding how we can maximize our access and actual proper use of these medications should be, oh gosh, Mr. Jones, did you bring your genetic counseling report? As I recall, you were a very high-risk patient, and I sent you on over to the genetic counseling as recommended due to your very high-risk disease. And typically the answer is, I never went. So many times having the wherewithal to follow up, because it's quite important to know really what the genetic and the genomic status is, has become even more important in how we treat M1 CRPC patients. I put up here just some red flags of hereditary cancer. I highlight that metastatic prostate cancer is now in the guidelines for NCCN. Many of us are not used to seeing this, used to ovarian and breast cancer and even colon cancer, but for your metastatic prostate cancer, please do not forget to send to genetic counseling or consider doing some sort of testing yourself. As we know from many publications, 90% of metastatic CRPC has some clinically actionable molecular alterations. There are different buckets of these actionable areas. So one of them being in the DNA repair space. So very important that understanding the DNA repair pathway can really impact our treatment selection choices. One of the ways to really think about it is understanding that DNA damage occurs a certain way and the repair pathway occurs a certain way. And having a better understanding of the BRCA1 and BRCA2 sort of role just for what it does for repair normally versus in the cancer space is very important. So I really encourage you to have a deeper dive into this area, but understand that there's several strategies that you can do, including germline testing, which there are saliva and buccal swabs that can be done to actually get the results. And then somatic testing, that in somatic testing, it's very important that you know that even archival tissue is helpful, although it's not ideal. And in a patient that has had treatment 20 years later, one would prefer getting a fresh biopsy, but if possible, to go ahead and test the archival tissue, as well as understand that there's a lot of circulating tumor DNA tests out there, and find out what is the right setting for your group or your practice. I think it's really important to know these things are existing. So it's really important now for Mr. Jones to understand that even in the M1 CRPC space, it's back to docetaxel. So just as it was important and available in the castrate-sensitive space, it's also available in the castrate-resistant space. And many of us do start and continue with docetaxel, even if there were prior docetaxel use, just as long as there's been a considerable amount of time in between. But one question that also impacts quality of life and cost is how much docetaxel is really needed. And I think there are a lot of studies in this area, but the general idea is that the survival benefit really is no longer detected after 10 cycles. So I encourage many of you who are thinking about giving docetaxel to set a limit, as the quality of life with regards to neuropathy and just financial toxicity clearly increase. And for those who wonder whether docetaxel use is different, considering with risk, in this particular study where there was a combination of multiple phase 3 trials with docetaxel, either alone in combination, showed that African-American men have statistically significant decreased risk of death compared to white men with use of docetaxel. So I think that setting our biases aside, understand that docetaxel is an option for many. I also just want to say that in our list that I provided earlier, why it's important to think about genomics after we think about the AR drugs as well as chemotherapy is because when you do these testings, sometimes there's a positive result. So here's a result from the lung biopsy that Mr. Jones had showing that he has a BRCA2 mutated pathogenic, as well as a germline testing showing the same BRCA2 abnormality. And that's important because in this pathway where we are worried or at least aware that homologous recombination repair mutation exists in prostate cancer, the world of PARP inhibitors has now come into the space of prostate cancer. Again, PARP is a protein that repairs single-strand breaks, and the tumors that have BRCA1 and 2 mutations cannot repair these double-strand breaks, so the use of PARP is important. And there are 2 big studies to support this. The first one is the PROfound study, which again just was updated at our recent ESMO 2020. At the end of it, it's now FDA approved as of this year in May, where those who have germline or somatic mutations are definitely eligible after receiving enzalutamide or abiraterone. And then the Triton-2 study, also similar, except that you need to also have had a taxane, but this also obtained FDA approval. So in the CRPC space, we have definitely increased our numbers. And in this hypothetical patient, he was treated with olaparib because he had the BRCA2, and more importantly, the genetic counselors were notified so that family members could be tested and so on. And unfortunately now for a hypothetical patient, he has progression of disease after another 18 months where he now has liver metastases. And in doing this, one of the things sometimes in the prostate world we don't think about is the use of immunotherapy. The only indication for the use of immunotherapy is for microsatellite instability or MSI high cancer. As you can see that in prostate cancer, 3% of the time, prostate cancer is MSI high, increasing your chance by at least knowing this by 3% that pembrolizumab is now approved for such patients. This is very important information, as is the recently reported IPAT study, which looks at ipatasertib plus placebo in patients who now have PTEN loss. And in this instance, it's more options for your patient. So Mr. Jones had pembrolizumab, unfortunately progressed some more. There's again more treatment options. He didn't want any more liver biopsies. He was tired of that, but it did agree to undergo a liquid biopsy. So the one question that always comes up is it the same? And in this instance, it's quite close. So they're not identical in terms of the somatic alterations, but similar enough where if that's your only option, it certainly is something to consider. And now that Mr. Jones has had so much treatment and is sort of gone through many of the standards, he now has an option for more clinical trials, of which I imagine that the PSMA clinical trials are one of the ones that your patients, your real patients probably is looking for. And there are many now in this field. One is the therapy trial, where it's been shown that the primary endpoint PSA response was at 50% when compared to cabazitaxel. There was another trial known as the Vision trial, again put here for your information for later use, and that we are awaiting the results of this already accrued trial, and that there are other trials in play, including the PSMA one using actinium-225. So this was a very, very quick run through in terms of what could happen with a patient and his journey, but it's really important to remember a few items. The first is please use the current clinical states model. I think it helps us really understand where the patient is in his journey and where the data sits in terms of what's approved and what's in trials. I think it's also important to know that as we're integrating so many things now with biomarkers and imaging and quality of life and cost, that many people have to be part of your decision-making group. So expansion of your multidisciplinary team might be warranted. I think the M0 CRPC space is really an emerging group, at least for now, depending on where imaging takes us. But this improvement of metastasis-free survival versus the impact of quality of life is something to consider and something to discuss. Please also recognize that there's so many challenges and opportunities to optimize these care, but one of the ones that's important is that if you don't do molecular testing, you won't know whether some of the items on the treatment menu will be something for your patient. So to consider genetic counseling, or if you take that on yourself, to make sure that that remains in your treatment armamentarium, and remain an advocate for your patient, knowing that cost and insurance coverage is always something that matters. And lastly, we are all in the midst of COVID, and the number one question I get now is, what do we do with COVID-19 and prostate cancer? And I think the answer is, we keep going. We encourage patients to maintain communication during the pandemic. Please assure them that their caregivers, that means you, are using best practices. And sometimes we can use new technology like telemedicine, or something like old technology like the telephone. And I think it's important to know that it's really just maintaining communication in any form to encourage your patient to seek care. We have had to perhaps do some different approaches, such as perhaps using different preparations, longer preparations of ADT, so that would help them recognize they don't need to come monthly or every 3 months. And that while we're waiting, even if they don't want to come in, but you think that it's important to do molecular testing, to take this time perhaps to look to see if there is archival tissue or newer tissue to be sent. Touching base with your genetic counseling team to also figure out next steps might also be important. And lastly, participation in clinical trials is always encouraged. Many centers around the United States have already figured out ways to work with clinical trials and how to ensure that your patient can enroll. Thank you so much for your time. It's been a pleasure.
Okay, we're here with Dr. Heath to answer some questions from the audience. So Dr. Heath, a couple of questions have come in from our audience. The first one is, how does the clinical states model differ or align with the NCCN guideline for prostate cancer?
Thank you so much, Gordon. And what a terrific question. They actually are very much aligned, and I think the advantage of the clinical states model is that it's the big overview. It allows you to be able to sort of compartmentalize what you see in NCCN. NCCN guidelines are very detailed, as many of us experience, and we look at those guidelines sometimes daily in our practice. But having sort of the broader 50,000-foot view of how we can categorize patients all the way from the local state to the metastatic space is sometimes really helpful. And so in that sense, it's probably much more aligned than they are different, but great question.
Excellent, thank you so much. The second question we have from the audience is, do providers prefer one treatment over the other two oral agents for M0 CRPC?
That's also a terrific question. I'm not sure if there's an easy answer. I think the fact that we have 3 FDA-approved agents in this space is always a welcomed piece of news. Anytime I have that as options, I'm thrilled. I think many of us in practice recognize that a lot of it is decision-making based specifically on your patient. So one agent might have more concerns about falls. The other agent is a twice-a-day medication. If you're a little worried about compliance, perhaps that's not the agent to go to. The other agent might have some more concerns with those with cardiovascular issues. So factoring in sort of the individual scenario for your patient is probably the best bet. We probably can't ignore that many of it is also driven by insurance authorizations. So several of us have experienced where you pick one, and this is what you say you're hoping to prescribe to your patient, but unfortunately, the insurance sort of does not allow that to happen. So one of the things I've learned in my own practice is to be quite broad about it, to say, well, the good news is there are many agents that are available, but we have to be practical and not spend thousands of dollars on drugs that are basically quite similar in its mechanism of action. So we have to be practical. A great question.
Okay, great, thank you. Is there any consideration for CAR-T for some small group of castrate-resistant prostate cancer?
We have a terrific audience. Everyone's coming up with
we always
really,
have a terrific audience.
Yeah, always have a terrific audience. I think the CAR-T question has come up more frequently now that we know of its successes in our liquid tumors. And the answer is yes, there will be CAR-T studies coming, most likely in 2021. I think, unfortunately, due to the pandemic, we have had probably some delays that are unanticipated, but the prostate cancer community is quite excited to embrace a new technology and really looking forward to it.
Great, we'll look forward to those results. For patients who have had abiraterone and enzalutamide and are BRCA positive, now ready for a PARP inhibitor, what is the PFS and OS cited in the studies?
Yeah, that's a great question, and I'm not sure if we're able to actually see that in the presentation, but I do want to say that be mindful of the two agents as they don't have the exact FDA approval. So as you may or may not recall from the presentation that the study that looked at, which was the PROfound study that had looked at olaparib, is approved in those who have failed enzalutamide or abiraterone. But that is different than the Triton-2 study, which is really approved for rucaparib for patients who have had an AR inhibitor and also had a taxane-based chemotherapy. So I want to be mindful that for your particular question in the audience, it's most likely referring to the PROfound study. So there are several endpoints, and as you alluded to with PFS and OS, so the median overall survival in the olaparib PROfound study was 18.5 months versus 15.1 months. And the imaging PFS was 7.4 for olaparib versus 3.6. So I want to point out this distinction for sort of the indication, because when it comes time to prescribe, I think your patient's insurance plan will also want to know the prior therapies. So great question.
Okay. I think we have time for one more here. Do you anticipate the M0 clinical state to change due to improving imaging technology?
I do. And I think you guys have heard in this lecture about all of the new PET scans that are emerging. And frankly, it's probably changing more than what we recognize just based on the current approvals of fluciclovine and others. I think as that field of imaging really improve in the next year, and I'm not talking 10 years, I'm talking in the next year, I do believe that the M0 state might shrink more than you think. Now, I'm always fascinated when I have patients with a rising PSA of 50 and you're scanning them and there's nothing. So there's this weird mix of disappointment and joy right in the same visit. But I do think that with improved imaging, this space will tend to shrink in the near future.
Great. Thank you so much for all the additional information. And we do have great audience members with great questions, which we encourage them to submit throughout everybody's presentation. So thank you very much, Dr. Heath.